Hello, future PTAs. I hope you guys are doing well. Today we're talking about traction. I'm trying to get the screen to cooperate. Okay. All right. So here is our outline and some of the effects of traction. Joint distraction, it opens up that joint space. Reduction of disc protrusion if they have a bulging or a herniated disc. Soft tissue stretching, stretching, muscle relaxation, and joint mobilization. Joint distraction. So that is the separation of two articular surfaces perpendicular to their plane of articulation. So with the um let's see, the vertebral disc, so I try and do my arms like it. If they are articulating and turning that way, the distraction pulls them apart that way. So it opens up that joint space to allow the disc to disperse more evenly and not be compressed. It reduces the joint compression, widens the intervertebral foramen, can reduce pressure on articular surfaces, intra-articular surfaces, and the spinal nerve roots. It would require enough force to open up the area. So 50% of your body weight for the lumbar joints or 7% of the body weight for the cervical joints. Reduction of disc protrusion does require sufficient force. So with the lumbar spine, it's typically 60 to 120 pounds, which is 30 to 60% of the body weight. With the cervical spine, it's typically around 15 to 30 pounds to open up that space, take the pressure off of the disc in order to allow it to disperse more evenly and not bulge so much. Some of the effects, it stretches and relaxes the soft tissue. So this tissue stretching can contribute to more distraction, reduction of disc protrusion, increase in range of motion, just kind of taking the pressure off that area. Muscle relaxation due to reduced pressure on pain sensitive structures or gating by intermittent traction. So remember, there's that pain, spasm, pain cycle where pain produces muscle spasms, which produces more pain and creates a continuous cycle. So if you come in and kind of stop that cycle by stretching the area and temporarily relieving some of the pain, then you could allow the patient to have some lasting effects from that. Joint mobilization, the way that it does it is by high force traction or repetitive or intermittent traction. It mobilizes many joints at a time, so it's not specific. Manual techniques are more localized, and um, mechanical traction is more generalized throughout the entire spine. Some of the indications, if someone has a spinal disc bulge or herniation, if they have nerve root impingement, if they have decreased mobility of the joints in the spine, if they have some type of joint inflammation that's not necessarily acute but subacute, and if they're having muscle spasms in the low back or the area that you're wanting to treat. Disc bulge or herniation, lumbar traction may decrease the size of the herniated disc material. It reduces compression on the spinal nerve roots. There is not a lot of clinical evidence related to the severity or location of the disc protrusion to give you exact guidance there. But we tend to see more positive outcomes in cervical spine than lumbar spine. And a lot of patients do tell you that it helps relieve their pain in both. With nerve root impingement, typically this is either associated with a disc bulge, ligament encroachment, so that's where the ligament is entering the space and pushing on the nerve. Foraminal stenosis. Stenosis is narrowing of the spinal column. So if it narrows too much, it pushes on the spinal cord and causes pain, and eventually it could cause injury if it narrows enough. Osteophyte, that's a bone spur. Nerve root swelling, just inflammation in the root itself, or spondylolisthesis. So spondylolisthesis is that sliding forward of a vertebrae because the pars interarticularis, which is the part that um, connects one spine of the vertebrae to the vertebrae above and or below it. If it breaks, if there's a fracture there, that bone is no longer stable and can move. So the two spinous processes that are typically fused together, there is a break and they are separated, and so one is kind of floating and can move. And if it moves anteriorly, that is called spondylolisthesis. Just the break itself of the pars interarticularis is spondylosis. So sometimes those are hard to keep straight. Spondylosis is the fracture, and then spondylolisthesis is what typically happens after a fracture. The vertebrae slides forward and pushes into the spinal column and can put pressure on the spinal cord or on the nerves that are exiting that area. Traction is best applied shortly after onset of symptoms, and in patients with worse symptoms with spinal loading, that decrease with taking the pressure off. So when they're standing and the gravity is pushing down on their spine, they have more pain, but when they're sitting or laying down, they have less pain. Typically, it's more effective with those types of patients. Joint hypomobility, traction can glide, distract spinal facet joints to increase their mobility. The effect, again, is nonspecific. It's very generalized and affects multiple joints at one time. The increased flexion localizes the force to the upper and lower thoracic versus a neutral or a more extended position localizes more to the lumbar spine. So the lady in the picture here is in 90 degrees of hip flexion. So it's primarily stretching her thoracic spine. And if you brought her legs down more, the closer to extension that she got, the more localized to the low back the force would be. Subacute joint inflammation, reduces pressure on the inflamed joint surfaces, and then small movements may do pain gating and maintain normal fluid exchange in the joints. So some of the effects are also from pain gating and just relieving some of the pressure off the area. With muscle spasms, static traction or low load intermittent traction may interrupt that pain spasm pain cycle. The higher load traction may reduce the underlying cause of pain itself. So in the picture, the bottom picture has a disc bulge that's pushing into the nerve. The top picture shows where the bones have been pulled apart by traction. They have been distracted and opened up the joint space. And now, rather than the pressure being placed on that intervertebral disc, it's relieved and the disc can go back into its normal place and not be bulging out. Contraindications, if motion is contraindicated, of course you wouldn't do it. If it is acute injury or acute inflammation, then you would not do traction, only with subacute, or even you could do chronic. It just shows the best benefits with subacute. If their joints are hypermobile or unstable, you absolutely do not do traction because you could paralyze somebody. If the traction causes their symptoms to peripheralize, remember we talked about with low back pain, you always want the symptoms to centralize. So if the pain's going all the way down their leg into the foot, and then traction causes it to, even if the low back is a little bit more intense, if the pain is no longer reaching the foot, but it's reaching just to the level of the knee, then we know the pain has centralized some, and that is the desired effect. If, on the other hand, the pain starts out in the low back, and after the treatment, they're like, the low back might feel a little better, but now I'm feeling something down my leg, that means it has peripheralized, and that's not what we want. That means there's more pressure being placed on the nerve. So we are always looking for our treatments to centralize low back pain and not peripheralize it. So even if the back pain is getting better, if the symptoms down the leg are getting worse, that's not the right treatment. You want to always work towards getting the symptoms out of the leg, even if it makes a little bit more discomfort in the low back pain, and then eventually the low back pain will also get better. And then if they have high blood pressure that's uncontrolled, then you would not do that either, as it could raise that blood pressure. With the precautions, structural disease or conditions that affect the spine, if the belt pressure would be hazardous, like with a pregnant person putting that belt on, if it would compress a little baby in there, we definitely don't want to do it with that, or even if the person has some type of wound or something healing or anything in that area. If they have displaced annular fragments, if there is a medial disc protrusion, which we'll talk about on the next slide, if they had severe pain that resolves completely with traction, like really bad pain, now it's completely gone. That seems kind of like, well, then the treatment worked. Well, if now it's completely gone and not just a little better, one um, one traction session should not really fully alleviate the pain. So you wonder and hope that it's not, if maybe they're not feeling any pain because there's actually more pressure on the nerve at this point, and it has cut off their sensation totally. So that's why you wouldn't want to see somebody with severe pain come out saying, "Oh, I have absolutely no pain anymore." Then you worry that the nerve compression has actually gotten worse to the point where they're not getting any input from it. And that is the opposite of what we want to do. If the person's claustrophobic, they may not be able to do traction. If they can't tolerate the positions they need to be in, like prone or supine, or if they're really disoriented, then they can't either. There's a few more precautions on a future slide, so we won't write these out quite yet. So this is what I was talking about with the medial disc protrusion. Um, so if there is a lateral disc protrusion, I was trying to get my mouse out so I could show you. As the space opens up, the nerve root itself goes a little bit more medial. So now it's further away from that protrusion and not as affected by it. However, in the same way, if there's a medial disc protrusion, as the joint space opens up and the nerve root goes more medially, it's actually going to be more affected by the medial disc protrusion than it was before the traction. So in that case, if you know that that is um, where the protrusion is, then you would not want to do traction. So making sure that if they've had an MRI, that you know where the protrusion was and that you read the report and understand it before trying traction. So two more precautions for cervical traction specifically is if they have TMJ, it could cause those issues to flare up, or if they have dentures, because it could actually damage those dentures. They could possibly just take the dentures out and you could continue with treatment. But if they don't, then you may not want to do the treatment. Some of the adverse effects of excessive force may increase their symptoms. There could be a rebound increase in pain. So initially they say, oh, yeah, things are better. And then throughout the day, their pain gets worse and worse as the disc starts to compress a little bit more over time with gravity. Then the nerve is getting compressed again and could cause them to be in more pain. Um, Sometimes the cervical traction could actually cause some lumbar symptoms or discomfort. So you want to just be careful how you set up the patient and that you're constantly asking them how it feels and assessing, and that you're assessing after the treatment as well as asking them when they come in for their next session how they felt, for the few days in between, and if they got very sore or what their lasting effects were. In general, we evaluate the patient, determine if it's safe to do traction, select the type of traction we want to do, explain it to the patient, apply it. Once it's done, we assess the outcome and then we document, just like with all of our modalities. With mechanical traction, there are different belts and halters that you could use, different positions you could put the patient in, different devices that you could use. Some of them are stable and big and expensive. Some are more mobile and they could take home with them. There is continuous traction and intermittent traction, and you would determine which of those you want to use based on the goals and the symptoms of the patient. So there's a lot of different variations of ways that you can use the traction. Some of the recommended parameters for lumbar traction. If the patient has initial or acute pain, which was already contraindicated, but we'll say subacute for the first, it's been more than 48 hours, but it's still within the first week or two. then you typically will do 13 to 20 kilograms of static traction for only 5 to 10 minutes. Now, the kilograms, since we usually use pounds, I kind of put the kilogram conversions below. I just rounded them so it's a little bit easier. So the 13 to 20 pounds is around 28 pounds traction. Um, if you were trying to do joint distraction, then you would need around 22 kilograms, which is around 48 pounds, or around 50% of the patient's body weight, which could vary greatly depending on the patient. You would typically have a 15-second on time, 15-second relax time. So we say hold and relax. We don't tell the patient that, but that's what we call the on-off time with traction. And you would want to do the treatment for about 20 to 30 minutes. If your goal is to decrease muscle spasms, then you are only going to use around 25% of the patient's body weight. 5-second hold time, 5-second relax time. So again, these are intermittent traction versus the static or continuous, and then 20 to 30 minutes of treatment time. If they have disc problems or you're wanting to get a stretch of the soft tissue, again, you would use around 25% of their body weight. And here you would use the longest hold times for a whole minute and a 20-second relax time for, again, 20 to 30 minutes. For cervical traction, with their initial first few treatments, you only want to use around 3 to 4 kilograms, which is between 6.5 and I didn't put 4, maybe 10 pounds, maybe not quite. Um, and you would do the static hold again and 5 to 10 minutes for their first few sessions to just make sure that they don't have any adverse effects before you start doing longer treatment times. For joint distraction, 9 to 13 kilograms, which was between 20 and about 28.5 pounds, or 7% of their body weight. And then this is where you will do the 15-second hold time, 15-second relax time, just like with lumbar traction, 20 to 30 minutes of treatment session. For muscle spasms, you would do 5 to 7 kilograms, which is between 11 and 15 pounds around about. And they could have the 5-second hold time, 5-second relax time for 20 to 30 minutes. And then for the disc problems, 5 to 7 kilograms, and they would have that minute hold, 20-second relax for 20 to 30 minutes. So the hold times and the relax times don't change between lumbar and cervical. The main thing that changes is just the weight. And again, in general, you use around 25 to 50% of the body weight for lumbar traction and around 7% or less of the body weight for cervical traction. I would personally start out with the less and make sure they tolerate it before I start increasing the pressure and the amount of weight, percent body weight that I'm using. Mechanical spinal traction, sorry. Some of the advantages and disadvantages. Some of the advantages is that the force and the time are completely controlled, graded, and replicable. You can replicate them easily and document them easily. It doesn't require continuous supervision. The devices aren't super expensive. They're pretty convenient. Some of them the patient can take home with them and use at their convenience. They're typically pretty easy to use. The disadvantages is some of the devices are expensive. We talked about inexpensive, but some are expensive. The setup and the cleanup is somewhat time consuming. The patient doesn't have a lot of control or participation. They're just kind of laying there, letting it happen. The belt and the halters may be restrictive, may be hard to put on. Sometimes if you don't have them tight enough, they'll slide and become in a bad position. And then the mobilizers, mobilizes broad regions of the spine. So it's not a general mobilization like you would do manually. It is a general, or it's not a specific one like you would do manually. It's general. So it mobilizes a lot of areas in the spine, and it may be areas that you don't want or need to mobilize. Some suggested positions for mechanical hip traction. So, if your goal is to relieve the patient's pain, then this top picture is more so where you would go towards you're going towards hip flexion and abduction and external rotation, which, if you remember, is the open pack position for the hip. So, that's the position where the bones are most open. And so, there's the least impingement, and that would be the most comfortable for the patient. If your goal is to increase hip range of motion, then you are going to go towards a more neutral position, towards more towards hip extension. You can do some abduction again, but we're going more towards internal rotation versus external rotation. Some of the parameters for hip traction for the first week, then you want a 1 minute hold time and 30 to 40 pounds of force typically, with only 6 to 8 minutes of treatment. For the next week, usually you'll do a 1 to 3 minute hold time, 40 to 50 pounds of force. Again, it's going to depend on the patient's body weight as well, and 12 to 15 minutes of treatment time. And after 2 weeks, you could go up to 1 to 5 minutes of a hold time, gradually increase from 40 pounds to even up to 100 or over, which is a whole lot. So be careful. And the treatment time would be up towards 15 or 20 minutes. Always assess and be very careful, slowly adding the weight. Self and positional spinal traction. um, Use your own body weight to exert a distractive force on the spine. So it could be used for lumbar, but not usually for cervical. When only a minimal amount of force is required, this can be helpful, but when a lot of force is required, it's not very helpful. And the pictures are three different positions that could help open up the spine a little bit and cause a little bit of a traction force. So, hanging from a bar, pushing up and relaxing your legs, but holding all your weight on your arms in a chair, or leaning back like on a countertop and dropping your weight down, can all open up the spine a little bit. An inversion table can be used as well, where you place your feet into some, something that holds you there, something stable. I can't think of the word, I forget words sometimes. And then lean back, and your head is in a downward position. So your body weight, gravity uses your body weight to open up the area and apply a traction force. It's primarily to the lumbar spine. When I was looking for this picture, I did see a few pictures where the machine is built to where you are in more of a flex position with the hips flexed to 90 degrees, which then, of course, would be more specific to your thoracic spine. But in this position, it's more for your lumbar spine. Manual traction, so we're applying the force by the therapist in the direction of the distracting the joints. So this, of course, takes a lot of good body mechanics and strength from the therapist. You can't typically hold it as long or put as much pressure, and you really have to use your body mechanics, because otherwise you're going to wear out pretty quickly, or could even pull a muscle. But I personally do manual cervical traction quite often, but don't typically do a lot of manual lumbar traction. Some people do, but I just personally don't do that quite as often. It's a lot harder to do and to get enough force to be very effective and to hold it long enough to be effective. Documentation, just like our other modalities, you want to document the type of traction you use, the area you applied it to, the position the patient is in, what type of halter you wanted or you used, what force you used, whether it was intermittent or continuous. And if it was intermittent, put the hold times, the relaxed time, the force during the relaxed time. So sometimes it doesn't go just all the way back to zero. It holds some traction force throughout. The treatment duration, and then the patient's response to the treatment. All right. I don't know if you guys noticed, but I made it through a whole lecture without sneezing. So that's an accomplishment. All right. That's it for us for today. And I will see you in the next lecture.